Good morning. Today's class is going to be on periodontal flap surgeries. So let me just start with sharing my screen. Yes. Yes. So today's class is on periodontal flaps. So in this content, we are going to see the definition, indication, contraindication, classification, types of incisions, flap techniques which are all commonly used, and we are going to see on the healing after flap surgery. So coming on to the definition, a flap is a section of gingiva and or mucosa surgically separated from the underlying tissues to provide visibility of and accessibility to the bone and root surfaces. So as it is mentioned, it can be both gingiva and or mucosa, which is surgically separated from the underlying tissues, and the main concept is to provide visibility of and accessibility to the bone and the root surfaces. And coming on to the indications, irregular bony contours, deep craters, pockets on teeth in which a complete removal of root irritants is not clinically possible without elevating a flap, grade 2 and grade 3 percussion involvement, root resection and hemisections, intrabony pockets on distal area of last molars, and persistent inflammation. These are all the prime indications of periodontal flap surgery. So coming on to the contraindications, uncontrolled medical conditions such as unstable angina, uncontrolled diabetes, uncontrolled hypertension, and a patient who has a history of myocardial infarction or stroke within 6 months, and patient who have poor flap control so that they will not be able to have the proper maintenance of these conditions after surgery, and high caries rate are all the contraindications for periodontal flaps. Coming on to the classification as such, the flaps are classified into various types based on 3 major categories. They are based on the bone exposure after flap reflection, based on the placement of flap after surgery, and based on the management of papilla. So as you can see, based on the exposure, it can be a full thickness or a partial thickness flap. Based on the placement, it can be an undisplaced or a displaced flap. And based on the management of papilla, it can be a conventional flap or a papilla preservation flap. So coming on to the classification based on the bone exposure, it is a full thickness flap. As you can see in this picture, after incision and during the elevation, the entire full thickness of the gingiva is elevated along with the periosteum and the bone is exposed. So the periosteum is reflected to expose the underlying bone in a full thickness flap, and it is most commonly indicated in the resective osseous surgical procedures. And in partial thickness flap, as you can see in this picture, the incision is given in such a way that only a partial thickness of the gingiva is elevated and a periosteum is perfectly covering the bone. So it is indicated when the flap is to be repositioned after the placement. So these are all the indications of partial thickness flap where it is going to be a displaced one. And coming on to the bone, so that is the classification based on the flap placement after surgery. It can be a non-displaced or an undisplaced flap and a displaced flap. As you can see, after the elevation of the periodontal flap in this picture, if I am going to replace the flap in its previous position, it is called as an undisplaced or a non-displaced flap. That is when the flap is returned and sutured to its original position. And a displaced flap is one when the flap is placed either apically or coronally or laterally to its original position. So coming on to the next classification, which is based on the management of papilla, either it can be a split, that is a conventional flap where the entire papilla is split, or it is a papilla preservation flap where we are going to preserve the papilla. In this picture, you can see the papilla is split into the buccal or the palatal or the lingual flaps. So you don't have an entire papilla as such. The papilla is split into a buccal and a lingual or a palatal component. In this picture, it is evident that after giving the incisions in the sulcular area, the entire papilla is incorporated to either the buccal or the palatal flap. In this picture, the entire papilla is incorporated into the buccal flap. So this is a papilla preservation flap. So coming on to the types of incisions, we have major categories like horizontal and the vertical incisions based on the plane of which we are giving the incisions. So horizontal incisions are the incisions which are directed in the horizontal plane along the margin of the gingiva. We have three types of horizontal incisions, that is the internal bevel incision, clavicular incision and the interdental incision. Now I will explain each and everything. Internal bevel incision, as you can see in this picture, this is the first incision, or this is the primary first incision in periodontal flap surgeries. This incision is always given with the periodontal, it is given with a surgical scalpel, that is a surgical blade is used. Number 15 is the most commonly used one. If you are not having number 15, it can go for number 11. But this incision is given at a distance from the gingival margin, which is aimed at the bone crest. The main indication or the main rationale of giving an internal bevel incision is it removes the pocket lining, it produces a sharp thin flap margin, and it starts from a designated area of the gingiva and is directed towards an area near the crest of the bone, so that your entire flap becomes pliable for you to handle. Coming on to the clavicular incision, it is a second incision. As you can see in this picture, this incision is made from the base of the pocket to the crest of the bone. So this incision together with the first incision or the internal bevel incision form a V-shaped wedge which ends near the crest of the bone, and this V-shaped wedge is the most commonly involved part of the gingiva which we want to eliminate. So coming on to the third incision or the interdental incision, this incision is given with help of a Orban's knife. It is given by separating the collar of the gingiva that is left around the tooth, and the incisions are made facially, lingually and in the interdental segments. So coming on to the vertical incisions can be given when you are going to displace the flap most commonly, and can be used either on one or the both ends of the horizontal incision. The vertical incision most commonly they extend beyond the mucogingival line and they will reach the alveolar mucosa, so that the entire flap is movable for you. And the major points which you should note when you are giving a vertical incision is that the vertical incisions are not given at the midline of the papilla. The papilla is not separated or the papilla is not dissected, and it is not, vertical incision is not given on the major convexity of the root surface. So the vertical incision is always directed towards the line angles of your tooth, as you can see in this picture. So coming on to the flap techniques, the pocket therapy indicates increasing the accessibility to the root deposits. It eliminates or reduces the pocket depth by the section of the pocket wall, and it exposes the area to perform the regenerative methods. And coming on to the few examples of the flap techniques which we use commonly are the modified Whitman flap, the original Whitman flap, the Kirkland flap, Newman flap, apically displaced flap, coronally displaced flap, and distal molar surgeries are the most common. These are all the most commonly used techniques, names. And coming on to the healing after flap surgery, immediately after suturing, that is 0 to 24 hours, there is an establishment of a blood clot which has fibrin reticulum, PMNS, erythrocytes, etc. And from 1 to 3 days after flap surgery, the space between the flap and the tooth or the bone is thinner, and the epithelial cells migrate over the border of the flap. And 1 week after the surgery, the blood clot is replaced by the granulation tissue derived from the gingival connective tissue and bone marrow and the period. So 2 weeks after the surgery, we have the collagen fibers which are arranged parallel to the tooth surface, and the union of the flap to the tooth is still weak because we have an immature collagen fibers. And 1 month after the surgery, a fully epithelialized gingival crevice with a well-defined epithelial attachment is present, and there is a beginning of functional arrangement of the supracrustal fibers is seen after 1 month of the surgery. So this completes our seminar on flaps. Thank you.